be discussing about post-operative rehab in cases after knee arthroscopy. So knee arthroscopy is a very wide spectrum, and we can do a lot of surgeries in knee arthroscopy, and the actual rehab is actually customized to the patient that we operate. So the rehab is different from patient to patient. There is no single rehab protocol that you can follow in all the patients. But I'll just give you a brief guidelines about what needs to be done. The first surgery, which is not very routinely performed by us, is a medial or lateral partial meniscectomy. It's a surgery which was done in past. It is a surgery which we don't recommend nowadays, because if you remove a part of meniscus, then you will lose the shock absorbing capacity of the knee, which can lead to osteoarthritis. But if you do that, there is one advantage, that you can rehab the patient very fast. So if you do a partial medial or lateral meniscectomy, you can start the patient weight bearing the next day, and you can start them on the rehab the very next day. You can start knee bending, weight bearing, and all sorts of rehab very early. So this is the first surgery, but very infrequently performed surgery in today's era. The second surgery that we do is called as a meniscus repair surgery. So if there is a meniscus repair that we do, you need to protect the repair till the time it heals. So meniscus is not a very vascular tissue, so we need to give time for the meniscus to heal. It depends on case to case basis, but usually it will take around 3 to 6 weeks of time for a meniscus to heal in its position. Okay, so what happens is, when we repair the meniscus, we need to assess the strength of the repair that we do, and after that we will ask the patient to follow that protocols. Usually in these meniscus repair patients, you can start knee bending at around 7 to 10 days. We will do suture removal at around 2 weeks of time, and approximately between 4 to 6 weeks of time, we can start the patient to bear weight and walk normally. A protective brace needs to be worn for about 4 to 6 weeks of time. Similar is the case with root repair. Still root repair, we will still do more cautious or slow rehab in meniscus root repair. So what is root? Root is the attachment part of the tree. So if there is a tree, there is a root which is there into the soil. Same way, the meniscus is attached to the tibia by the root. So if there is a root avulsion, it is equivalent to a total meniscus loss. So we need to attach it, and if we attach the root, again you have to give 4 to 6 weeks of time minimum for that root to heal in its position, so that the meniscus becomes functional. The third surgery that we do is a ACL reconstruction surgery. Okay, ACL reconstruction surgery alone, you can mobilize the patient little faster. You can start weight bearing also early. Usually we give about 3 weeks of knee brace just for support and rest. The patient can weight bear the next day. He can start walking also with the help of a crutches or a walker from the next day. And about 3 weeks of total support is needed. After that, he is able to walk without support normally. But he should be cautioned not to play sports, not to do heavy activities, and not to indulge in heavy twisting turning activities like sports and dance. This may take around 3 to 4 months. Okay, so sports not before 4 months, 3 to 4 months. A different category of the patient is those in which we do a primary ACL repair. It's a rare surgery that is performed in which the stump is good and we repair the original ACL back to its native place. It's not a very routine surgery, but if it is done, the rehab is little quicker and the patient can be asked to play earlier as compared to a ACL reconstruction surgery. The fourth scenario is combination of ACL and meniscus tear, and usually in this combination the meniscus tear repair protocol is usually followed as well. So almost non-weight bearing may be needed for about 3 to 4 weeks, and the knee brace should maybe be worn for about a month or so. Okay. Okay, so this is the rehab for the patient who has mixed ligament and meniscus surgeries. The fifth category of patient is those patients in which we have done procedures for cartilage like mosaic plasty, like stem cell insertions, something like that. So what in those cases what we have done is if there is a cartilage defect, we fill it up with bone plugs or bone blocks. So if it is so, then again you need plugs with the defect. So if it is there, you need to walk non-weight bearing for a period of 4 to 6 weeks again. After that comes PCL injuries. Now PCL are the worst of all injuries in the sense that it is a difficult to do procedure. It's a technically demanding procedure. There is a high risk of surgical injuries or complications as well. And there is a high risk of late ruptures or late failures as well, because PCL is a very strong, bulky ligament. And if there is a PCL injury and you have done an augmentation reconstruction procedure, you need to protect it more as compared to any meniscus or ACL surgery. So we usually recommend minimum 2 to 3 months of bracing. Now for PCL we recommend a brace which is called as a jack brace. What is jack brace?
Posterior.
Very good. So you can use a brace which can bend at the knee level, but it should have a posterior support, because if there is a PCL tear, the patient will have a posterior sag. The proximal part of tibia will sag downwards. So this brace will push the proximal tibia upwards and give the support to the tibia. So you use the jack brace ideally for a period of 2 to 3 months, and weight bearing usually we delay for about 2 months. So 1.5 to 2 months minimum the patient should be non-weight bearing, and after that he should start weight bearing. And rehab also is slower start of sports also you may take 4 to 6 months of time. So if there is a PCL injury, again you should do a slower rehab. The other combination is a multi-ligament injury. You can have ACL, PCL, MCL, and then it goes about patient to patient that how much surgery we have done, how much repairs we have done, and we need to balance among two things: the rate of laxity which can come and the patient may develop stiffness. So you need to balance these two things and do your rehab accordingly. So in those cases, if the rehab may needs to be customized or a patient specific, whatever the patient needs. And occasionally you may also change the rehab pattern. So if you are following up the patient and if you see that the patient is going into stiffness and the range of motion is not coming, you can start more aggressive rehab, because some of these patients may develop stiffness or tightness sooner than some of the late patients. There is one concept that if you operate them early, the chances of stiffness is more. So, but it is not always true. So it may be happening that if you operate some patients little early, you may have higher chances of arthrofibrosis, but that is okay, because arthrofibrosis is one thing that you can treat easily. It's not that difficult to treat. And in some scenarios, like in case of a severe multi-ligament injury in which 2 or 3 ligaments are torn, if I develop arthrofibrosis, I am actually happy, because they will give more stability, because they are very unstable knees, like a knee dislocation patient. And if he becomes a little stiff, I am happy, because there is some fibrosis which is occurring and which will give the patient some sort of stability. So stiffness or arthrofibrosis may be good also in a subset of patients in which you have very bad knee dislocations or very severe ligament injuries. So it will give some sort of stability to them also. So these things need to be balanced and it needs to be customized from one patient to another. And these patients should be in very close watch and close follow-ups, and a very close work between the operating surgeon and the physiotherapist is very important in these particular cases. Okay, any questions?
In all cases, we can start knee bending after suture removal or before.
We usually start knee bending in 7 to 10 days. But if you delay it from there, it may lead to stiffness. So whatever repairs we have done, we usually start within 7 to 10 days knee range of motions. And depends, you may not allow the full range of motion, but 0 to 90 degrees is very safe, so you can allow it within 10 days. In pure ACL, you can allow even earlier. If the meniscus repair has not been done, you can start in the second year also. No problems.
So in patients with ACL rehab, more importance is to be given on hamstring strengthening.
Yes.
And
Yes.
in PCL, suppose it
Quadriceps.
get to quadriceps.
Yes. because these are antagonistic
Antagonistic.
muscles. So that is exercises. And what is closed chain exercise? You should know this.
When it's both agonist and antagonist muscles will be
What is open chain and what is closed chain, and what is recommended for ACL? So if your distal part is fixed, that is recommended. So that is, so we don't want, supposedly if you have this is free and if you do this is open chain, and if this is fixed on the ground and then you are doing range of motion, it is better. So in ACL, because if you are doing an open chain, there is more forces on the ligament per se. So I don't believe in it much, but just for theoretical purposes, they are better. If your distal part is fixed, it is better. If you're just moving, then it has got more strain on the ligament.
Then we can use CPM. CPM machine is
CPM is good. CPM is, we don't have CPM facilities for all the patients, but yet if a good manual rehabilitation with a good physiotherapy is usually what we need. Okay.